All right, thanks, Dave. So welcome, everyone. As Dave mentioned, my name is Heather Johnston, a PhD candidate here at York, and it gives me great pleasure to welcome our two speakers under the topic of muscle physiology. So first, we have Dr. Sunita Mathur from the University of Toronto. So I'll pass it to you if you want to turn on your microphone and video, and I'll stop my sharing.
Sure. Thanks, Heather. And I will start mine. Hey, thank you for the invitation, Dr. Hood, to speak at this meeting. We're going to be changing direction a little bit towards more clinically based imaging and measurement of muscle. And the title of my presentation is Sarcopenia in Chronic Lung Disease and How We Evaluate It and Its Relationship to Health Outcomes. So I'm going to first speak about what is the problem of sarcopenia and its impact on health outcomes, specifically in respiratory disease conditions, because those are the conditions that we study in our research lab. And then I'm going to spend most of the talk talking about how we measure sarcopenia in a clinical research setting. So this is a first example, just to give you an idea of what sarcopenia looks like. This is an example of a man who is in his 60s who came into the intensive care unit and was put on mechanical ventilation for 2 weeks. And he had already come in with a little bit of muscle loss. He was a little bit older and he already had chronic lung disease. But during his hospitalization, which lasted over a month, he lost a lot of muscle mass. And there are several factors that contribute to that muscle mass loss. So of course, advanced age, not doing anything while you're on bed rest in the hospital, not eating properly, the number of medications you get put on, often they have side effects on muscle, developing sepsis or poor blood gases, and a series of other sorts of inflammatory cascades, poor glucose control, a decrease in anabolic hormones, and also any other premorbid conditions that you already come in with. So you can experience quite a bit of muscle loss while you're in the intensive care unit. And this is coming, of course, more in the media right now because of COVID-19, and people are spending time in the ICU with that disease. And then when they're coming out, even younger people not able to regain walking or standing up. So really a profound loss on your mobility when you come out of the ICU. But in addition to muscles contributing to our movement and mobility, it also contributes to our overall wellness and health. And this was an early study done in 2002 that showed that muscle cross-sectional area in people with lung disease was actually an important predictor of mortality. So they looked at 142 people with chronic obstructive pulmonary disease, which is one of the most common chronic diseases amongst Canadians. And they found that mid-thigh muscle cross-sectional area, in addition to lung function, were the only significant predictors of mortality. Now in COPD, we already know that lung function is an important predictor of mortality because it is a lung disease. But this was the first study to show that mid-thigh cross-sectional area was also an important predictor. And if you look at the survival curve, you can see this red line, it's going down quite drastically. So people that had a combination of low muscle mass and poor lung function had a very low probability of survival. And then even more interestingly, they found a cutoff that if you had a mid-thigh cross-sectional area less than 70 centimeters squared, it was actually independently associated with a 4 times increase in mortality rate. So again, the first time showing that in a lung disease, it wasn't just lung function that predicted mortality, but the most important predictor was actually muscle cross-sectional area. So that tells us about the importance of muscle and muscle mass in our overall health. So since then, muscle atrophy, muscle wasting has been studied much more in people with COPD, looking at its clinical implications. So beyond just movement and impaired movement and sit-to-stand tests and things like that, it's been associated with physical disability, poor quality of life, increased risk for being re-hospitalized, which can lead to further loss of muscle. And then it's been confirmed as an important predictor of mortality in this particular disease condition. So when we talk about muscle wasting, the term sarcopenia is also used. So now sarcopenia is being used more and more in the literature. And originally its literal translation is poverty of flesh. And it was originally defined as an age-related decline of muscle mass. So as people reach their 70s and 80s, we would see a decline in muscle mass, and that was termed sarcopenia. And the focus of measuring sarcopenia or defining it tended to be on the measurement of low muscle mass. Now, since then, there's been more attention paid onto sarcopenia and how to define it, because it's been shown to be such an important predictor of health outcomes across many diseases, as well as with aging. So in 2019, there was a revised consensus definition. It actually came out to say that low muscle strength was the key finding that should be used to define sarcopenia. And once low muscle strength is defined, then we can look at low muscle quantity or muscle mass, also muscle quality, and then low physical performance. So it's actually a combination of three things, with muscle strength being the most important now. So muscle strength, quantity, and physical performance all define sarcopenia. The other thing that's been noted more and more in the literature is sarcopenia is accelerated in chronic disease. So it's not only seen as we get into our older ages, 70s, 80s, and 90s, it's actually seen in younger people, 30s and 40s, when they have a chronic disease. And there's actually also been studies shown in children that have chronic disease that show that they experience sarcopenia. So sarcopenia is no longer just an age-related change, but something that we can see in chronic disease, and again, an important predictor of overall health and well-being. So how do we evaluate sarcopenia? So as I mentioned previously, the focus had always been on muscle mass, and it's still a very key aspect of the sarcopenia definition. So much of what we do when we study sarcopenia is try to evaluate whole body muscle mass. Now, one of the key measures that can be used for that is DEXA, where we can look at whole body and segmental, so arm or leg or trunk muscle mass. And the other one that's used quite commonly is bioelectrical impedance analysis, which is much simpler to perform than DEXA because you can. It's a much smaller device. It just takes a few minutes. And from that, we can derive percent of fat mass and percent of fat-free mass. So in the consensus definition, both DEXA and bioelectrical impedance have been used as the markers for looking at muscle mass, or the suggested measurements. But some of the limitations that we have doing DEXA clinically is that there is some radiation exposure. Not everyone wants to have that extra radiation. There's a cost and time and access issues to having a DEXA scan done. Bioelectrical impedance analysis is much simpler to do, but it's often critiqued for accuracy. So you may even have used a device like this when you go to the gym, and people often say, there's error associated with your hydration status. If you drank too much water or not enough water, that can affect it. The amount of exercise you did before you did the measurement. So it has to use very standardized procedures for you to get an accurate measurement. In our lab, we use a variety of muscle imaging approaches. In addition to DEXA and BIA, which we do use, we also use MRI, computed tomography, and ultrasound. And with these imaging modalities, we can examine specific muscle groups and look at their size, the architecture of muscle, so fiber lengths, fiber angles, and also muscle composition or muscle quality. So we can look at fatty infiltration of the muscle or fibrosis of the muscle. So MRI and CT are considered gold standards when you're looking at muscle size, muscle architecture. But they do have higher costs. They require time for the subject to undergo the scan and quite a bit of technical expertise, both to run the scans as well as to do the analysis. So they're not used, that widely, definitely not for clinical purposes, really only for research purposes. And we've also moved our research into using muscle ultrasound because that's a little bit more doable, especially in our critically ill patients that might be in the hospital or in the ICU where we can't be sending them for MRIs and CTs because they're so sick. We can do ultrasound at the bedside. So with ultrasound imaging, this is a picture of just how we have our ultrasound set up in the lab, and it's a portable system, so it can be taken over to the hospital. It's very easy to do. It's you can look at muscles, individual muscles and muscle groups, and get very nice images. So this is an example of imaging the quadriceps. We can see a cross-sectional view of the quadriceps, as well as a longitudinal view to look at muscle thickness. One of the limitations, however, of ultrasound is if you compare it to MRI, where you can see the entire leg, you're really just looking at one muscle at a time. So what does that really tell us about sarcopenia? Because what I mentioned before is we wanted to look at muscle mass. Muscle mass is what we're concerned about. Will one individual muscle really tell you about sarcopenia? This is an important question that we'd like to explore. So can ultrasound be used to identify sarcopenia? So there has been a study done in healthy adults. It was quite a large group of 96 people with an age range between 24 and 72. And they validated ultrasound against DEXA to look at segmental muscle mass to see, if you just took some ultrasound images, would that give you enough information about the muscle mass of the entire limb? So they had a 4-site model where they took images on each quadriceps, so 2 sites on each quadriceps, and they correlated the sum of those measures to appendicular lean mass from DEXA, which is considered a gold standard. And they did find a very good correlation, and you can see the agreement line there. It looks very good. But very interestingly, when they added just one more site, so they took another site on the anterior upper limb, so around the biceps, added that to the model, in addition to accounting for age and sex, that improved the correlation to 0.91. And even more importantly, with the 5-site model, they were able to identify people that had low muscle mass. And that's really what we're critically interested in with sarcopenia, is trying to figure out who are those people with low muscle mass. So if we could do that with ultrasound, that can be done much quicker than doing it with DEXA. And it can be applied to many more patients, such as the ones that we look at, who may, as I mentioned, could be in the hospital, they could be in the ICU. And so we can't be sending them for these extra imaging modalities. So we're doing a study right now that I'm going to talk about a little bit at the end of the presentation, where we're going to try to validate a similar model using ultrasound against DEXA in people who are undergoing a lung transplant. And we're trying to validate this so that we could more easily identify people with sarcopenia that are undergoing transplantation surgery. Another method that we've been using to evaluate sarcopenia is using CT scans that are already readily available. So this is a CT scan actually of the chest. So you can see this is an image taken in a person with lung disease to look at their lungs. And what we did is use the same image to outline their muscles as well as their fat deposition. So we're trying to use these CT scans that are already available through routine clinical imaging to monitor lung function, to look at muscle and fat. So the advantage of this is that the scans are already being done, so they're already part of the person's medical record. The person doesn't have to undergo any additional testing or radiation exposure. And it also gives us the ability to examine larger data sets because it's all in the medical record. So retrospectively, we can go back and measure scans and look at clinical outcomes to see how the two are related. So we have applied this method in patients with advanced lung disease, and we've established the reliability of measuring both muscle and fat, very high reliability with just minimal amount of training and knowledge. We've also looked at the validity of the measure for muscle and fat compared to bioelectrical impedance. So this was done in a group of 50 patients undergoing lung transplant, and we found moderate correlations to muscle mass and fat mass. And we've also compared our measures of muscle from the chest CT to other sarcopenia measures. So generally, when we measure sarcopenia, we're looking at lower limb measures. So it did correlate with quadriceps cross-sectional area from ultrasound and quadriceps strength. So we find that this is a promising measure moving forward to do larger studies to look at health outcomes in people with advanced lung disease. So in one of these studies, we did a retrospective review of lung transplant candidates at the Toronto Lung Transplant Program. And in the study, we were able to include close to 300 people, whereas when we bring people to the lab to do ultrasound or DEXA or BIA, we really only have studies of about 50 people. So this was a real advantage of using this technique. And we found that their muscle cross-sectional area was associated with pre-transplant exercise capacity, so that people with a lower muscle area had lower exercise capacity. And in terms of clinical outcomes, people with a lower cross-sectional area of muscle on their CT scan also had a longer hospital stay after their transplant. So this translates into healthcare costs and also the overall health of the individual. Now, this technique that we've used has also been used by other researchers around the world. And we recently are working on a systematic review and have found 15 other studies that have used CTs of the chest in people with lung disease to look at clinical outcomes. And these were all done in people undergoing lung transplant. And we found that other researchers have also related this measure to clinical outcomes. So CT muscle mass has been related to the days on mechanical ventilation or length of ICU stay after a transplant. And in one study, it was even linked to survival at 1, 2, and 3 years post-transplant. So that was very interesting to see as well. So this is a promising technique that we're hoping to use more. As I said, we can use it in larger cohorts of patients so we can look at these important clinical outcomes. So now we'll turn our attention to measuring muscle function or muscle strength. So in the lab, we use a computerized dynamometer, or Biodex. And if you go to any movement performance lab or biomechanics lab, you'll see these types of devices. And they can be used to measure muscle strength, muscle endurance, and also muscle power. Now, muscle strength is the key part of the definition for sarcopenia, but there is greater attention now on muscle power because that combines both force and velocity of movement. It seems to be more related to physical function, and it also declines quicker with age. So perhaps it also declines quicker with sarcopenia, but that has not been studied, and it's one of the things that we're looking at in one of our current studies. Now, when you go into more of the clinical setting, a biodex or a similar dynamometer cannot be available. It just takes up too much space in the clinical setting, but also the time required to do the testing is just not really reasonable. So mostly when people do strength testing clinically, they use hand grip strength. It's very simple to perform, takes a few minutes, and there's also normative data available. So you can tell a person what percent of predictive they are. So you can tell them if they're weak or if they're within normal limits. So this tends to be used quite a lot for a sarcopenia measure. However, what we found is that hand grip strength is actually less sensitive to picking up weakness than leg strength. And we did this study in people undergoing lung transplant again. And we found that if we used hand grip strength, we only found that about 36% of our sample was considered weak based on being lower than the mean of the distribution. But when we used quadriceps strength, it was just over half of the group that was actually found to have weakness in quadriceps. So our preference is actually to use quadriceps strength because that can help identify people earlier if they have sarcopenia. But how are we going to do that clinically? Because we can't really put a biodex in the lab in a clinical setting. So we've been coming up with other methods that could be done much simpler in a clinical setting. So this is called a fixed dynamometer. This is an alternative to that larger computerized dynamometer. It's just a small device that can be put under a hospital plinth, and a person can sit on the plinth and have their quadriceps strength measured. The test takes less than 10 minutes to perform, and we've done a multi-center study in people with chronic obstructive pulmonary disease to show that the protocol is quite feasible. There's high agreement between this MedUp device and our gold standard biodex. And so currently, one of the limitations of using it clinically is there are no normative data. So people want to know, clinicians want to know, can I tell my patient that they have normal strength? Are they weak? Just like with hand grip strength. So currently we're working on an international multi-center study where we're going to have over 250 people, healthy people, to develop a normative data set using this dynamometer so that it could be more useful in the clinical setting. And it could also help us in the evaluation of sarcopenia because it could tell us if somebody's actually weak or not. So the last aspect of the sarcopenia definition is measuring physical performance. And there's many tests to measure physical performance. The one that's recommended is the short physical performance battery. And this has 3 components. The first test is a balance test where you're asked to stand with feet together, semi-tandem or tandem stance. And if you're able to hold the tandem stance for 10 seconds, you get 4 points or maximum score. You also do a walking speed test where you're asked to walk 4 meters and the gait speed is tested. Again, if you fall at a certain level for gait speed, you receive your 4 points. And then the final component is a sit to stand test. So again, a time test where you're asked to rise from a chair 5 times as fast as you can. And that based on that time, you're awarded a certain number of points. So the maximum score on this test is 12. People that rate lower will get less score. And a score of between 9 and 10 is usually used as a cutoff for poor physical performance, or sometimes used as a cutoff for frailty or sarcopenia. The other benefit of this test is that you can also look at the individual components. So walking speed on its own is a very good predictor of physical well-being. Similarly, the sit-to-stand test on its own. So you can use either the point system of the short performance battery or the individual components. So we do tend to use this test quite a bit. So in one of our studies, we examined the presence of sarcopenia in lung transplant candidates using bioelectrical impedance for low muscle mass. We use quadriceps strength for low muscle strength, and we use the short physical performance battery to identify impaired mobility. And what we found in this study was that low strength and impaired mobility were the more common factors that were found than low muscle mass. So this is more in line with the current consensus definition for sarcopenia, where it says low strength is really the critical factor. And we defined sarcopenia in this study by having 2 out of the 3 deficits. And we found that people that had sarcopenia had lower exercise capacity, lower quality of life, and greater hospital length of stay after their transplant. So again, just showing that sarcopenia is a very important predictor of health outcomes in this particular disease population. So I'm just going to briefly mention a study that we're currently conducting. It's called FROST, Frailty and Sarcopenia in Solid Organ Transplant. So we've done quite a bit of research in the lung transplant group to look at muscle dysfunction or sarcopenia. And we found that muscle weakness and atrophy is present before lung transplant. It declines even more after the transplant because people are in hospital, but it does recover, but not completely. 3 to 6 months post-discharge, and that's even with undergoing a rehabilitation program. So there is something sort of lacking that we can't get that full recovery. And as I showed in the previous slide, we found that close to half of lung transplant candidates meet the criteria for sarcopenia, with most of them having deficits in strength and function. But what about other types of patients, other types of organ groups? So now our larger study includes lung transplant candidates, but also includes other types of organ transplant groups. So for our sarcopenia current study, we're trying to identify a single measure or a combination of sarcopenia measures that are the strongest predictors of pre and post-transplant outcomes. And so those are things like survival on the wait list, hospital stay, dysfunction of the organ, and health-related quality of life. And we're also trying to validate clinical measures of sarcopenia to lab-based gold standard measures. So in this study, we're including 240 solid organ transplant patients. So again, lung, but in addition to that, liver, heart, and kidney. And we test them before the transplant, and then 3, 6, and 12 months after the transplant. And we're doing a whole battery of sarcopenia measures, a combination of gold standards and more clinically relevant measures. So we're using DEXA scan for muscle mass, but we're also trying to validate ultrasound and our clinical CT method. For muscle strength, we're using our Biodex, but we're also using our fixed dynamometer, the MEDUP, for quad strength, and we're including hand grip to see how well that performs. And for physical performance, we're using the short physical performance battery, the total score, but also the individual components to see, can we just use one of these tests rather than the whole battery to predict sarcopenia? So that study is currently underway. Hopefully the next time we have this conference, we'll be able to share some of the results. So I just want to end with some key messages from the talk. So first, the onset of sarcopenia is accelerated in people with chronic disease, and there's many factors that relate to this, but it's important to know that sarcopenia is not just something that occurs in older age. Sarcopenia is associated with clinical outcomes, and we've shown this in chronic lung disease, things like hospitalization, quality of life, and mortality, but this has been shown in other populations as well. And the evaluation of sarcopenia requires muscle strength, size, and performance measures. And the validation of clinically applicable measures are needed so that we can move some of these findings into the clinical setting, and clinicians can actually identify people who have sarcopenia and provide them with adequate strategies to mitigate it. So I want to thank you for your time and open it up for any questions.
Heather, you're muted.
Muted there. Thank you. So thanks for that presentation. So for anyone who has questions, again, you can ask that through the Q&A function, and we'll send them along, and I'll be able to ask some.
Can I have a question? Because I have a hard time using my Q&A. Imed Gallouzi.
Great. Okay. Go ahead, Dr. Gallouzi.
So this is a really great talk. Thank you. And I learned a lot. So a question regarding sarcopenia, it is like a cachexia. It's a complex syndrome where diagnosis is very important, and that's you're doing great there. But when it comes to lung transplant patient, is there a predictor or way to measure the function of the diaphragm because at least my few readings, it is possible that lack of function or dysfunction of the diaphragm can be the trigger for downside outcome can be predicted even for sarcopenia, or patient will deal with that with transplants properly or not?
Yeah, that's a great question. Actually, we are involved with a study with one of my collaborators where we do diaphragm imaging and quadriceps imaging. So we can do diaphragm imaging using ultrasound, looking at the thickness and the movement of the diaphragm. And to measure its function, it's used respiratory pressure. So inspiratory muscle pressure can be used. But the diaphragm imaging, it looks like it's quite promising. And yes, you're right. Like when people are when they have severe lung disease, diaphragm dysfunction, of course, is a major problem. And in the ICU as well, when they go on mechanical ventilation, the development of diaphragmatic dysfunction becomes, a key issue as well. Now, which one predicts post-transplant outcomes better, whether it's limb or diaphragm or a combination, that's not something we know yet, but that is a study that's going underway right now at Toronto General.
Yeah, thank you.
Heather, I have a question, if I may, please.
Yes, go ahead.
For the exploitation of the CT scans, which muscles are you looking at? And it's kind of a multi-faceted question. Is that which muscles are you looking at? Are they predictive of mortality, like say the quad cross-sectional area was? Mm-hmm. And then can you go a step further and look at the Hounsfield unit intensity to extrapolate, say, IMAT, intramuscular adipose tissue, in those CT scans?
Yeah, great question. Yeah, I didn't get into the details there. So we did a couple of different ways. So the first study we did, we looked at all the muscles individually. So we separated out pectorals, paraspinals, so erector spinae. This is at the level around T4, so thoracic level 4. So yeah, pectorals, erector spinae, serratus anterior, latissimus dorsi. We did them all separately. And then we also looked at them as a sum. Now, going forward, we found the best method, both time efficient and giving us the same amount of information, was the pectorals separately and then the total muscle. So we use both of those. So we measure the pec separately and then everything else. So that's how we do our muscle measure. And we are looking also at the Hounsfield unit. So again, I didn't present that data, but yes, when we looked at the Hounsfield units for muscle density or intramuscular fat for those muscles, we did find that it correlated with the overall fat mass that we derive from bioelectrical impedance. So that was interesting. And using it as a predictor for future, like in terms of mortality or health outcomes, we haven't done it yet, but in the current study that we're running, where we're going to collect in a larger group of patients, we are going to derive the muscle density as well, the Hounsfield unit. So we'll see what we find in terms of mass versus muscle quality. But I think that's an important question to answer.
Thank you.
Great. And we have one more question online from Travis. So with the wide range of tests you are performing with your current research, do you find clients prefer certain tests over others? And a follow-up to that, do you think fatigue might factor into this given the high volume of tests?
Yeah, okay. So in terms of fatigue, definitely. We don't do all the tests on one day. They are quite sick, the patients, because they're waiting for transplant. So the DEXA is done on a different day. They come to our lab and do the biodex and the ultrasound. And then the other strength test and the short performance is actually done by the physical therapist at the rehab gym at the hospital. So it could be divided up into 3 different sessions when they're coming in for various appointments. So fatigue is definitely a factor that we have to weigh in. In terms of preference, I think people like tests where the results mean something to them. So the short physical performance battery, it makes sense when they see that they can't get out of a chair without using their arms, that it's eye-opening, like, oh, I'm really weak. And we can also tell them, this is where we expect you to be, this is not. When we do the quads test on the biodex, for example, it's harder for us to sort of explain what that means. It is also more cumbersome to do. Ultrasound, of course, people are always interested in seeing the pictures, but again, we can't tell them a lot. So I'd say when we can give them meaningful results, it's more important. And that's why we're doing that normative data study with our fixed dynamometer. So then we can then say, just like with hand grip, you're 70% of predicted, we think you should be higher, or we expect this to go up with rehabilitation. So yeah, I think where there's a meaning attached, it's much more helpful to the person.
Great.
Sunita, can I ask one last question? Heather, is this okay?
Yep, you've got 3 minutes.
Oh, good. Sunita, I just wanted to thank you, first of all, for joining. I know you're on sabbatical, and so I know you took time out from what you were doing to join us. It sounds like you have a very good core facility of muscle testing, muscle assessments. Are you open to collaboration? Are you very, very busy? And would people who study aging, for example, or is it just for a clinical population, would you be open to research in those areas?
Yeah, we've never actually had a chance to just look at pure aging, and I'd really like to do that. We've always, worked with kind of the hospital settings, and my background had been in lung disease for my PhD, so I kind of focused on that area. But I think looking at aging would be great, and we're open for collaboration, definitely. I know Arthur came down once a couple months ago to do a presentation, and that was great. And I think it's really nice for us to be able to bridge between the more fundamental muscle work and what we can do on a clinical level. We do work with a group at Unity Health, St. Michael's Hospital, which I know one of the MSc students presented from that group. So we do some biopsy work with them. And I think it's always nice to kind of combine the two. You can learn a lot more that way. So yeah, definitely open for collaboration.
Very good. Thank you, Sunita.
Sure.